Now, we'd like to begin the event organized by the Ministry of Health and Labor Welfare under the theme for better nutrition in the elderly. Hello, good morning, good afternoon, good evening, everyone. I am a doctor. Over the past 30 years, I have been working at the Ministry of Welfare, Labor, and Health. And I have been worked a lot of things, but the important things I remember is that Japan was the first to introduce public nursing care system, the insurance system. But before the implementation of that system, I was involved, and even after that, I took the various roles. The nursing care insurance were given to those who are in need of various medical or other supports. But the main of the services is related to nutrition. Through such activities or initiatives, what I found that it just not providing nutrition, having them have a good level of nutrition is not good enough. We need to consider how to improve their dietary habit in their daily life. That's what we thought. And I was public officer, and at the time, and after that, I attended the Japan Society related to nutrition. For example, Japan Society of Nutrition Care and Management, or the nutrition clinical practices. And I do not need to stress the importance of nutrition to you here, but so this is the very essential fact or practice in daily life. However, we want people enjoy eating. That is another important factor. So in order to become happy, we eat. So we need to always remember that to advance our initiatives in nutrition. Japan is one of the longevity countries, but at the same time, the society is super aging. In such aging society, various regional activities had been advanced. So today, we will think about nutrition and dietary habit, and we ask 7 distinguished experts to their presentation. And so Japan has rich experience and knowledge, and we have also perspectives for the future. So if the information shared today will be useful to you. So now I would like to welcome the today's presenter. First, we'd like to welcome Professor Katsuya IIJIMA, Director General of Institute of Gerontology, the University of Tokyo, also the Professor of Institute for Future Initiatives, under the title of the Health Problem of all the adults in Japan and the prevention of sarcopenia-related frailty. So thank you. Hello, everyone. Thank you very much for giving me such precious opportunities. Now, I'd like to start with my presentation. So today, I'd like to present health challenges that elderly in Japan is facing and talk about establishing a vigorous age society. Above all, I'd like to focus on nutrition management for the elderly and raise the issue of frailty, especially sarcopenia, weakened muscle state, as a topic for our discussions. Eventually, I would like to create a healthy, active elderly. So this is the background. As you know, it has already become a consensus and worldwide, but the longevity is extending, especially in Japan. health life expectancy, health longevity, where people can live independent is also extending. However, there's an issue, which is the gap of those two different lifespans. So as is shown in the middle, so the gap of these two different lifespan is about 10 years on average of men and women. However, I would like to decrease that gap. And the bottom shows it is particularly for the elderly men, the isolation of the from the society. So when they were young, they were working at the companies, but after retirement, they find it difficult to blend in the community, so they lost activities that leading to the malnutrition. So one of the things I like to present, the main part is flail. I like you to remember flail. This comes from the flailty in English. So back in 2014, the former body of Japan Geriatric Society called for addressing the issue of flailty, and in Japan we use the term flail, which comes from the flailty, and to prevent the elderly from becoming fragile. And so there are three pillars described being here for the prevention of flailty. The first, robust. Actually, the phrase is fast. It is a period of one's health status being between robust and requiring nursing care. The secondary, the reversibility. So it is the period where one can reverse its deteriorating health by appropriate improvements in daily life or intervention. So it's up to the yourself to improve the situation. And thirdly, you see the colorful wheels on the right top. The flail has multifaceted aspect, and not only one becomes frail physically, but also physiologically, cognitively, or social become frail, and they are very complicated, a very comprehensive way of thinking. So in order to create negative chain and one loses capacity to be independent. So we want them to review their lifestyles to prevent flailty. So Dr. Lindfried called for flailty cycle as shown in this diagram. So this was made into Japanese version. So since due to the constraint of time, I'm not going to explain in detail, but this depicts negative cycle. In the center, it says sarcopenia, weakened muscle. So if you do not active, do not move physically, the consumption of calories decrease, and you do not feel appetite, you do not eat. It starts from something very minor, small things. However, eventually, the frailty emerge. But what we need to pay attention is the left side, and psychological or social aspects are also the important factors to create such situation. So this slide incorporates two perspectives: the prevention of metabolic syndrome and prevention of flailty. Those may be misleading. However, depending on the age, the importance where they need to look at needs to be changed. And I'd like people to understand. And to that end, I created this slide. So we are going through the 1980s or 2021, but so when the people are around 50 or 60s, of course, you need to control diet, prevent metabolism related to disease. However, so gradually, the prevention of low malnutrition and low nutrition needs to be care, especially when people become 70s or 75 years old, the late stage. You people need to consider how to prevent becoming the condition of frailty. So the issues you need to care change that we call gear change. So Bmi Paradox is a term written in the middle. So I'd like to elaborate on that using the next slide. So this is the BMI paradox or obesity paradox, in other words. On the left side, this is the middle-aged people's data. The right-sized old-age data, horizontally BMI, and from the left side, the lightweight, middleweight, and heavyweight, and the hazard ratio of health hazard ratio is shown. Of course, in the middle-aged people, the BMI actually there's a V shape, so the less underweight, overweight equally have a high risk. However, when we look at the older age, actually the middleweight and overweight, there aren't many people like that. Even actually people gain weight more than average. That does not affect the mortality of those people. So we have conventional idea of BMI and control of the diet. So we need to consider more differently by people's age. So this shows the protein intake on the left side and food diversity on the right side. It's needless to say that we need to take protein sufficiently to prevent flail. And as for the variety of food, the diversity of food, the importance of which is shown among the Japanese data. So now I'd like to discuss frailty, especially for sarcopenia. And we conducted a cohort targeting independent elderly over 10 years. The name of the study is Kashiwa. So we identify various wisdom from that. So in this cohort, we used questionnaires. So 260 or so questionnaire was asked to each elderly. So I cannot show you the evidence in detail, but this is the summary. There are three pillars for health longevity. So first, nutrition on the left side top, especially diet and oral function, and physical activity left down. Of course, exercise is really important, but when you age, not really active physical activities can also work. And then third pillar is social participation. So there are various levels of social participation, but the important thing is connecting with people. So we have been under COVID-19 situation for 2 years now. Even people they get good control of the nutrition, but people become frail because of the lack of the connection with the people, the lack of social activities. But still, there are a certain level of elderly who still maintain the social participation activities, and they do not have frailty symptoms. So the nutrition, physical activity, the social participation or connection with people are considered to be three main pillars. It should be incorporated in one's daily life altogether. So I'm not going to show the raw data behind this cohort. However, so instead of just working on one factors or pillars, if a person satisfy all these three factors of the pillars, this chance of frailty is proven. So I'd like to show different data. The first, smart visual system. Of course, as written here on the top, we have to make an approach to each individual as well as the regional basis or community basis. First, we have anti-inflammatory diet that I'd like to explain. So if you eat, so you do not need to you need to consider the balanced diet, but when we consider the aging status, the chronic inflammation is pretty much involved. In order to enjoy food, it's better to select the food item that's anti-inflammatory. So longer run, if you select the less inflammatory or anti-inflammatory food items, then that will work better for your health and longevity. But then what we can do to support that, and there's a score to shows that dietary inflammatory index, DII score, and this using this you can know visually the balance of your diet if it is anti-inflammatory or pro-inflammatory. And I also said the importance of oral function. I think it was 5 or 6 years ago. We came up with a new term, oral frailty. It doesn't mean people cannot eat. A slight minor change in oral function. Sometimes people have an issue of aspiration or cannot swallow well or find it difficult to chew. The uncomfortable feelings in orals started to increase. And then over, for example, 2 years observation, so the oral frailty aggravates. And in total, for years, we did a tracking survey, and then actually the number of the cells around the oral started to melt. And so we want to raise the alert to everyone who needs to take care of the oral functions at earlier age. So we utilized 80,000 questionnaires to identify the condition of oral frailty, and also we took the another approach and came up with the some recipes that enhance chewing activities. And also, I'd like to talk about the training of what we call frail supporter. So they are the communicator of our evidence. So they do frail check. The nutrition, the social activity, the physical activities, and oral functions. They check one another among themselves, and they notice each other's difference and encourage it to one another to improve their situations. So these are always evidence basis. And in total, currently, the 82 local governments are started to this activities. This is for resident, by the resident type of activities. And this shows the interdisciplinary collaboration of multi stakeholders, industry, academia, and the government work together to create the next generation community. So that cannot be achieved just by government or the academia or the industry. All of the three entities need to collaborate to create a next generation community, especially the longevity focusing on the dietary habit. Thank you very much. That concludes my presentation. Dr. IIJIMA, thank you very much for your presentation. So for the nutrition or dietary habit, and he introduced us some evidence, and diverse level of approaches are necessary, and especially the control of the nutrition levels, the balance for the each individual elderly by age was found to be important. Thank you very much, Doctor.
The next speaker is someone who is working on nutrition improvement targeting the elderly in the community in Yamato City in Kanagawa Prefecture. So that is Professor Kazumi Tanaka, who will talk about community-based approaches. She is also a professor at a university. It's called Kanagawa University Human Services. So there's the keyword human services being part of a name of the university, so they consider this important. There's Dr. Shiro Abe, who's the president of the university, that pointed out the importance of that. So the current president of this university is the chairman of Nutrition Society, Mr. Teiji, or Professor Teiji Nakamura. The key point of human services may be expanded on some other occasion, but the keyword here is community-based. Sorry to have taken a longer time to introduce, but Professor Kazumi Tanaka, please go ahead. Thank you, Professor Miura. So I would like to talk about the locally based initiatives to prevent malnutrition of elderly residents. My name is Kazumi Tanaka. I am the registered dietitian and nutrition program advisor in Yamato City. Thank you for this opportunity. Yamato City is located in Kanagawa Prefecture. It's about 40 kilometers from central Tokyo. Population is about 240,000. And there are major 3 railway lines and 8 stations located here. And most of the city areas is within 15-minute walk from stations. And the population over 65 years old is 24%. The policy of Yamato City is to promote healthy city. So the health of people, health of city, and health of community are considered important, and there are more than 1,000 projects that are running for these purposes. So there's Healthy City Library called Sirius, where 10 million visitors came in 3 years. Now I would like to talk about malnutrition prevention program for elderly residents in the city of Yamato. This is the survey results done by Yamato City to prevent the long-term care. In order for the elderly to be independent, prevention of malnutrition is of the highest priority, as shown on this chart. Other issues like social isolation, lack of exercise, depression, oral health, and cognitive function requiring long-term care and the leading to death compared to those factors, malnutrition would lead to long-term care and death at the highest rate. So now I will talk about specific initiatives. Yamato City started from a year ago the nutrition consultation program. What is shown here is what was done last year. The registered dietitians would provide the nutrition consultation. The purpose is to improve health and also to improve the quality of life. The procedures start out with the health checkup, and within 6 months, if the body weight loss is more than 2 kilograms and if the body mass index is less than 20, then they will become eligible for screening by the nutrition consultation experts. So they will conduct first consultation, and then 3 months later, they would evaluate the behavioral objectives set at the outset. And then 6 months later, they would evaluate the results. This was done on a visits basis, but with COVID-19 pandemic, these days, the consultation is conducted over the phone. The weight loss of the elderly can be multiple causes, and these causes are interdependent. The nutrition consultation incorporates attentive listening and to set the personal goals that are feasible. In terms of specific support regarding nutrition, various ideas to increase the amount of calorie intake, informing appropriate dietary intake amount, and to provide advice regarding proper diet. Apart from that, not just about nutrition, but regarding social activities and various resources and advice of physical and social activities are provided as well. Also, they would correct the wrong knowledge that people have about health and diet. So as a result of the consultation, about 80% of the target either maintained or increased body weight. Those that saw improved body weight saw improvement in not just improvement in nutrition, but better physical condition and fitness, better mental health, and increased social activities as well. As the nutrition level recovers, the percentage of death and the need for long-term care have been reduced. This was done in 2021, or the nutrition consultation was done in 2020, and 6 months later, the evaluation was done. Those that received nutrition consultation and those that did not because they're not at home, etc., we compared the two groups, and those that have gone through the nutrition consultation saw 11.6 percentage point decrease. The annual long-term care cost in Yamato per person is 1.12 million yen, so per person, so times 13 means that Yamato City was able to save about 14.5 million yen. Not just the long-term care related costs, but this would also lead to reduction on social welfare costs. As such, the initiatives taken by the municipality is quite advanced, and this was introduced at the Council on Economic and Fiscal Policy as well as a successful case. Currently, this is being promoted across Japan as comprehensive health and long-term care operations. The life functions of the elderly and medical aspects were taken into account, and as shown on the diagram, there's multi-sectoral cooperation so that support can be extended for the elderly to lead an independent and healthy life. Also, in order to improve the malnutrition, the environment in which they live is also important. The areas that have high incidence of death and malnutrition had the characteristic of fewer nearby food stores. So these are the areas with need of improved access in terms of public transportation availability. It is also thought that access to food stores is lacking as well. So not just nutrition and long-term care related departments, it is extremely important to cooperate with other sectors. So the city hall and local municipal governments initiatives would improve not just the malnutrition, but also would lead to improvement in other aspects of life. They have the data regarding long-term care, so going forward, evidence can be produced going forward. So the prevention of malnutrition in the community needs to be collaborated and has been collaborated with other sectors, and we can expect a good outcome. So this can contribute hugely to the policy of leaving no one behind. Thank you very much for your attention. Thank you very much, Professor Tanaka. So with the keyword of community, as I mentioned earlier, she talked about the administration, such as the municipal government. So the improvement in nutrition would lead to improvement in health and prevention of diseases, but not just that. But from the administrative perspective, as was pointed out earlier, the social welfare cost can be reduced and can be utilized more efficiently. So that is a major key point, I believe. Thank you very much. Ms. Tanaka.
続きまして、
Now, we'd like to welcome Ms. Kumiko Tanaka, the chairperson of the Japan Dietary Habit Association. Ms. Tanaka will talk about grassroots activity by volunteers for dietary improvement. And the association was established in 1955. And at local governments across the nations, as volunteers, they are promoting to improve nutrition and dietary habits. And this is the association who manage and organize all those volunteers. So their slogan is achieve our health by our hands. So about 130,000 volunteers are working. It's huge number. So, and this association organize of them. So, Ms. Tanaka, please. Yes. Hello, everyone. I'm Kumiko Tanaka, the chairman of the Japan Dietary Habit Association. I'm honored to have this process opportunity. So you may think why I am wearing these pink T-shirts. Actually, so this T-shirt is worn by all volunteers for dietary improvements. So I'd like to put on these T-shirts and make a presentation for today. So let me start. Please have a look at the right side picture. This is the what we call kitchen demonstration bus or kitchen car, providing guidance on nutrition. That's our association started. So this is the very starting point of the activities by volunteers for promoting improved dietary habit. Today, I'd like to history of the volunteer activities and also our focus, the senior cafe for the prevention of the flail in the elderly. So first, I'd like to share with you the history of the Japan Dietary Habit Association and the birth of our volunteer group. So we started from the kitchen car. In July 1954, we started from just one vehicle. And 10 years after the World War II, in 1955, in Japan, although Japan got out of famine, the level of nutrition was insufficient. The infant mortality rate was high. So the lack of nutrition was considered to be very important issue. So in order to improve the diet of the Japanese, together with the like-minded people in other business sectors, we established this association. And at that time, there was an inquiry about developing the market for the extra produce imported from overseas. And we were asked if there is an effective advertisement method. And we started the kitchen car inspired by that. And in 2 years, we owned 8 vehicles in 1956, and we promoted education on nutrition, and we traveled a lot for 4 years until 1940. From the north to south, 574,895 kilometers. The travel distance is traveling the Earth 14 times. So we would use the ferry. We went everywhere because there weren't many places where dietitian can cook, and the access was bad to agriculture area, the fishery area, the mountainous area. But we had a kitchen car that was a mobile kitchen, so it became very popular. So we went everywhere, mountainous areas, squares, condominium, shrines, and we did demonstration and had a cooking class. But inspired by this cooking demonstration, the women living in agricultural mountainous coastal areas started their own cooking classes. So it was considered it's necessary to have the community-based activities to improve people's diet habit. So we started collaborating with the local governments across the nation. And later, the public health center took the initiative and created the nutrition nutrition course training, and where volunteers learned collect knowledge and skills. So around 1955, the association started to organize those volunteer groups. The volunteer groups who completed this nutrition course training say they want to live healthy, want to expand the circle of health, and they want to make themselves useful to that. And out of that wishes, they started to expand their activities based on the neighbor-based gathering. However, although those groups existed, but they were not really systematically organized, so some disappeared. But in 1970s, we started working with the former body of the Ministry of Health and local governments, and decided to organize these across the nation. And so we established the association in 14 prefecture, one special city, with the member of 17,419 people. And so it was initially the liaison council, but now the name was changed to the volunteers for promoting improved dietary habit. And so the organization called National Association of Volunteers for Promoting improved dietary habit was formed. So it started from the activities by women, but now men participate. So the total 121,232 members are working on to help create the health throughout people's life. So last year, under the COVID-19, we need to take precautions, but we provided the education to 6.1 million. So let me introduce specific activities. So left side is the kitchen class, and the right side is visiting homes. So it is again based on neighbors gathering. So they would cook dietary balanced bento box, share some cooked meal or activity to check the salt level, etc. And the activities are evolving. Also, we distributed foods at the time of disaster. And on the right side down, it's the scene advocating about food and nutrition at supermarkets and streets. So now the society aging, environment is changing. And after 50 years since the establishment, we are trying to match the needs of that time. So now I'd like to discuss senior cafe for the prevention of frailty. The society is aging. We have been conducted various activities targeting the elderly. But since 2018, we started to focus on senior cafe to prevent the elderly from becoming frail or do not let alone or lonely isolated. So as Dr. IIJIMA mentioned, the prevention of frailty are important, and there are three factors: social participation, nutrition, and physical activities. So we reach out to elderly who do not go outside. Even though they cannot go far, they can actually get together at the city hall or even their own houses. So we started based on the small community unit. So this shows the actual scenes using luncheon mat, which depicts the diet balance. And sometimes we would serve snacks and teas, and sometimes we cook together, like the picture. So cooking together, eating together, and they have fun while enjoying learning the balanced diet, and they feel like participating more. And as for the physical activities, as shown in the picture, so we do locally popular exercises. So now the exercise are arranged or customized to each local. So you may not feel like doing exercise alone, but if you work with others, you can have fun and understand the importance of doing that. The below is the festival scene in Akata, and volunteers are participating wearing these pink T-shirts. They actually walked around in the street. That's also the physical activities, and also became the PR activity to promote the importance of nutrition and dietary habits. So as for the social participation, as shown in the picture above, we do the counter card games. So the volunteers have been organizing senior cafe and communicated importance of having friends. For example, this is the traditional card game. So we, the association, created our own version to let them fun and also learn something. And below, also involve the children to let people socialize across generations. And because of the COVID-19, the our restrictions were posed for outing, so it was considered the fluidity among elderly will advance. But even under the COVID-19, we do not want to let the elderly alone or isolated, so we started to focus on, again, the visiting homes. So volunteers, the National Association Volunteers for Promoting Improved Dietary Habit was organized in 1970. Since then, over the 50 years, under the slogan of Achieve Our Good Health Ourselves, we have been reaching out the neighbors, the families, and we are united and did volunteer activities. I think in under the COVID situation, supporting each other is considered particularly important. So the those volunteers are the social capital that can be used. So to develop an advanced what we call community symbolic society and community-based comprehensive care system, the use of those volunteers for promoting improved dietary habit will be essential, and we will work hard with people at the communication communication public health center to realize a society where everyone is healthy and active. Thank you very much, Ms. Tanaka. So it was the presentation from the perspective of volunteers. So I have one question. Oftentimes we tend to think just of ourselves, but recruiting volunteers and raise the motivation of volunteers, maintaining motivation. Would you explain how to do that? Well, in order to maintain their motivation, letting them have fun. That's very important aspect. Yes, having fun. Of course, unless you have fun, you cannot continue. That's very good comment. Thank you.
Next, we will hear from the private sector. So we will hear about the food delivery for the elderly. I'd like to call upon the chairperson of Japan Nutrition Support Food Delivery Conference, Mr. Takashi KURODA. So this conference, Japan Nutrition Support Food Delivery Conference, in order to realize the ideal food delivery, they are engaged in various activities. Even if nutrition is important, if you don't have actual food to eat, then it's pointless. So in that sense, specific initiatives of delivering food is something that we'd love to hear more about. So Mr. Kuroda, please go ahead. Thank you for your kind introduction. So I will talk about the home-delivered food, which is the infrastructure for delivering food to the elderly. In Japan, in order to promote the food delivered to homes, there's what's called the Japan Nutrition Support Food Delivery Conference, and I serve as the chairperson. So what is home-delivered food? There is no clear definition in Japan, so it might be difficult to get an image of what it's like for those from countries and regions where there are no similar services. You can think of it as lunchbox type meal set of one serving size to be delivered to home. The difference between this and Uber Eats is that it is premised on providing at low cost by cooking large amounts of food at the same time. That way we can supply food to the elderly who is facing economic difficulties. So as in Japan, there are quite a lot of a number of the elderly, and with the physical and cognitive function deteriorating, there are many elderly that are unable to cook at home or purchase food items. Also in Japan, there's an increase in the number of the elderly taking care of the other elderly or the elderly living alone. So that has promoted the use of home-delivered food. Of course, aging society is not the only factor. There are many other social factors such as medical, long-term insurance, long-term care insurance systems, food culture, a view of life, and others. This is significance on nutrition in the aging society. It is quite easy to understand that nutrition can change the mortality rate. Even if you don't end up dying, it is still important in allowing the elderly to live a healthy life. It started out with the NPOs and volunteers that started out on a very small scale in the community. But now there are, largely speaking, two ways. One is that a chilled food would be delivered daily on a relatively small scale. Another way is to cook on a large quantities basis as frozen food and would be delivered using courier services. In reality, there are many minute differences in terms of the number of menus available and degree of customization to address certain types of disease. And also the elderly may have difficulty chewing, so they might customize in terms of adjusting the softness. And also there are different ways of delivering. So there are a wide variety of different home-delivered food services. The elderly would pick the appropriate vendors depending on the region that they live in and the situation that they're in. Based on this, as for this market, based on the data provided by Yano Research Institute, currently there are about 300 million meals per year that are being provided. Some of these have adjusted the softness or nutrition level, but most of these are normal food for the elderly. The frozen food is growing, but it is still mainly chilled food at the moment. As Ministry of Health, Labor and Welfare, they want to promote the market soundly, and they have created the guideline by incorporating various members from medical professional, long-term care professionals, etc., and created brochures as well and shared successful cases. So they are engaged in various ways of communication. Apart from this, the Consumer Affairs Agency has the certification system for food for diabetics and kidney diseases patients as well. For the purpose of promoting this guideline as well, the conference has been set up, and currently there are 33 companies that are part of this conference, covering about 2/3 of the meals provided in the market. So home-delivered food is developing, but there are issues and challenges. First is cost. Many of the elderly live on pension or on past savings, so they have the requirement to keep the cost of meal at $4 to $5 or less. Because of that, there's a risk that companies may engage in price competition. Reducing price may lead to a risk of the nutrition level being lowered. Another challenge is labor shortage. Aging society means that there are more elderly compared to working population, so meals being delivered to individual homes of elderly will continue to be difficult. And last is loneliness. As was explained a few times in earlier sessions, loneliness among the elderly is a very serious issue. In Japan, there are many elderly living alone, so providing home-delivered meal means that we end up promoting eating alone at home. Loneliness has high degree of causal relationship with mortality rate, more so than drinking, obesity, or smoking. So what should suppliers do in light of these challenges? What we are thinking is to provide a place where the elderly can get together and eat together. And by delivering to a specific place, we can reduce the delivery cost, and that can be allocated to increasing the level of nutrition and make the delivery cost more efficient. We can avoid eating alone, and by doing so, we can strengthen the function of meal, which is to connect the relationship or connect different people. At the moment, we are suspending our efforts because of COVID-19, but we are doing this on a pilot basis. I'll give you some examples. In depopulated areas, utilizing the cooking facilities at schools that were no longer serving as school, we can cook and provide meals. The elderly in the community would cook for others. So that would serve as a sense of mission and would be very rewarding. That will enliven the lives of those that receive the meal and those that cook the meal. So this is the local residents becoming the main actors. So this leads to a healthier life as a result of being engaged in activities for the sake of others. This is another example of providing meal to a community meeting space. So some people say that they end up eating a lot more as they eat with others, laughing and talking. So this would increase the amount of food and also increase the level of communication. We also provide lecture on nutrition. And that points to the importance of dietitian. By having dietitian intervene among the elderly after their discharge from the hospital, that can reduce the rate of rehospitalization. We have such evidence. We have nutrition care station, which supports the elderly among the communities. So we are starting to see the creation of dietitian that would visit individual homes. In the company that I run, Healthy Network, we provide comprehensive nutrition support services of providing meals and other services. What becomes very important is the existence of dietitian. In aging society, the role that can be played by dietitian can be increasingly important. Lastly, I have talked about the model case in Japan. But having revitalized communication through meal and having through meal, it can contribute to happy lives. That is common across the world, I believe. So please continue to pay attention to what we are doing in Japan. Thank you, Mr. Kuroda. So from the standpoint of a private sector company, you talked about it, but you provide all sorts of creative ways to accommodate different needs of the elderly. I'm sure you faced various difficulties. I have one simple question. This time with COVID-19, there have been a lot of impacts that are felt throughout the society. What was the impact on your business? Anything to be highlighted? Just to say the conclusion first, there were virtually none. The exchange among citizens, that became not possible. But those that were unable to go out because of physical conditions deteriorating, we provide food delivery services, and that remained unchanged. We didn't see an increase or we didn't see a decrease due to COVID-19 either. Thank you. That point is quite important. It's not just about demand for meals. It is a need from an expert's perspective. There are always a certain levels of need that need to be provided and satisfied. So that was proven, I think. Thank you very much for your presentation. Thank you.
日本
So now I would like to move to the next. Ms. Kayoko Maeda, Chairman of Japan Home Nutrition Management Society, she will discuss nutrition support at home for the elderly. The society he chair provide the nutrition guidance, and all members are working on that. Ms. Maeda is also the professor of Mukogawa Women's University. The elderly, especially those are cared at home, the nutrition level is weak or they are in vulnerable state. So visiting their homes is important. Actually, I have been doing that for a long time. But when I went there, opened up their refrigerator, nothing was there. So that's what I remember. So now I'd like to turn to Ms. Maeda. Thank you very much for a kind introduction. So I am the a chairperson of Japan Home Nutrition Management Society, providing the dietary support to the elderly living in Japan. I'm Kayoko Maeda. Nice to meet you. The Japan Home Nutrition Management Society is the only society in Japan to practice nutritional dietary guidance at home. In Japan, registered dietitians have been providing nutritional dietary support by visiting the homes of patients receiving medical care since around 1980. These dietitians are called home visiting registered dietitians. They work closely with patients and their families to support their ability to eat by mouth until the end of lives. So dietary and nutritional problems of home care recipients include dysphagia, difficulty with preparing meals, and reduced dietary intake. So registered dietitians at a hospital or clinic visit the patient's home to provide dietary support. The request of visit may come directly from the doctor, the person himself, or his family in oftentimes. So this shows the flow of dietary support at recipient's home. Step 1, 2, 3 is the flow from the recipient still in hospital to the dietary instruction by visiting his or her home after the discharge. At step 1, the patient will go through the screening process to identify necessary supports after the discharge. And in that screening, the dietitian will make assessment from nutritional viewpoint, such as risks in terms of food eating, dysphagia, low nutritional level, and so on. Step 2 is the case where the patient and his or her family have concerns about nutrition and food eating, although they wish to go home. Services available after the discharge, including home visiting dietary support, will be explained. And step 3 is at the time of conference, before discharge of the patient, the intention of the patient and his or her family will be reconfirmed, and the information will be shared between the hospital staff and home care service staff. The confirmation will be made in together, approach of care, types of services. If the patient and his family wish to have home visiting dietary support, then the dietitian assigned to that family will ask the main doctor to create the instructions on food eating. Step 4 is visiting to patient's home. Step 5 is when dietary support is provided at the recipient's home, the dietitian will bring some tools to make physical assessments of the patients, such as a measure, pulse oximeter, thermometer, pressure gauge, or stethoscope. And step 6 shows when visiting the recipient's home, they after greeting, they instead of starting diet instruction right away, the dietitian will check visually how the patient is doing while talking, and not only physical states, but also they would check facial expressions, conversations, to assess psychological and social aspects. Step 7, the dietitian will check to grasp the food intake volume. So by doing so, as shown in step 8 and 10, so what is the drug adherence? What are the hematological test results? How much the patient has eaten? Eating habits will be confirmed. So dietary support at recipient home is provided not only to improve the patient nutritional level or level values, but also support so that the recipient can live at home the way he or she wishes. And figure 2, the chart 2, so the dietitians are continuing their dietary support service even under the COVID-19 situation. This man is 75 years old, for example. He's mainly suffering from spinal injuries and diabetes. He cannot he cannot change his posture by himself. So while he was in hospital, he started to find it difficult to swallow. So his doctor had recommended him enteral nutrition. But his wife wants him to come home and eat foods at home until he dies, as her husband has always enjoyed eating. So she's trying with the help of dietary support at home. Based on the science ways of cutting food ingredients, she can prepare the meals for to the satisfactory to her husband, including visual. His glucose level is not controlled. So that visiting dietitian will provide advice to the wife and at the same time trying to reduce her fatigues from nursing care by listening some complaints from stress or show appreciation to her efforts. And figure 3 is the case providing home dietary support to patient at end of stage. So this patient is a 99 years old woman. So her doctor diagnosed that she has aspiration pneumonia and Alzheimer's disease. She has a speech problem. Her family wished her to eat from her mouth until last. Her doctor had prohibited feeding her with foods from her mouth due to the aspiration pneumonia, but her family wanted to have their mother taste some ice cream and coffee that were mother's favorites. So to make such wishes come true, the nurse, the speech therapist, and dietitian had proposed her last meal to her main doctor this, and the doctor gave them approval. So this shows how they are doing. So using the little spoon, but use something different. So put the food on the tongue of the patient, and immediately the speech therapist take it out after mother taste it, and then a nurse check the pressure, her pressure. So this is how they did it. So what is the role of the dietitian? So a dietitian actually made ice cream, creamy food made from the ice cream with a bit of coffee with an addition of non-heated gel so that ice cream would not melt and flow in her mouth. So, and then speech therapist, after confirming the mother felt it and tasted, took it out. So so they took turn and they feed their mothers from the eldest son, the first daughter, second daughter, twice each. So they were able to realize their dream of letting their mothers eat something from their mouth. And actually, mother passed away 2 days after this. So finally, in the future, there will be a growing need for nutritional dietary guidance for home care by dietitians who offer face-to-face services. So the Japan Home Nutrition Management Society will continue to provide support to many registered dietitians who can practice nutritional dietary guidance at home. So we would like to widen the scope from the after the discharge to the end of people's life. Thank you, Professor Maeda. So so we were impressed and became emotional knowing what they do at patients' home. So supporting eating from discharge of the hospital to the very end of their lives. So through the visiting dietitians support, we were so overwhelmed and impressed. But on the other hand, so dietitians who manage the home nutrition, I think I hear there aren't many dietitians who are capable of that. So there's a lack of dietitians across the nation. How do you try to improve? So in order to increase the numbers, in order to invite everyone who want to try, we will create a nutrition care station at community. Okay, thank you very much.
Next, we will hear from someone in the academia. So we will hear about the creation of a guide on dysphagia diet. So I'd like to call upon Professor KOJO, who is from Japanese Society of Dysphagia Rehabilitation. So this academic association has been engaged in various activities to prevent dysphagia and also to promote the maintenance of health among the citizens. Ms. KOJO, please go ahead. Thank you very much, Professor MIURA, for your introduction. I serve as an executive board member. I'm from Japanese Society of Dysphagia Rehabilitation. I'd like to extend my gratitude for the opportunity to give a presentation. I would like to talk about the creation and dissemination of a guide on dysphagia diet for medical and welfare professionals. The Japanese Society of Dysphagia Rehabilitation was established in 1995. It's an academic society. This is the only academic society emphasizing a transdisciplinary approach of dysphagia rehabilitation as shown on the pie chart, and there are speech therapists, dentists, registered dietitian, nurses, and others. So such medical professionals that amount to more than 16,000 belong to this academic society, engage in various activities including research, education, popularization, and structuralization in dysphagia rehabilitation to facilitate resolving the problems in individuals with eating and swallowing difficulties. So who has eating and swallowing difficulties? In addition to post-stroke patients, they are post-operative head and neck surgery or cancer patients, patients of chronic neurologic diseases such as ALS, Parkinson's disease, neuropathy, and dementia, those that are frail, and the patients of neurologic trauma and brain injury. The incidence tends to become higher with age. Because of that, there are many with dysphagia in Japan, as Japan is an aging society. There are three main problems that can be caused by dysphagia. The first is that there is risk of aspiration pneumonia or choking with eating. Secondly, they're unable to have sufficient meal. This can be the cause of malnutrition or dehydration. Thirdly, they are unable to enjoy eating. So as shown, with the changes in eating habits, the quality of life can be decreased. This can also be seen as a problem that threatens human dignity. So regarding these problems, the texture-modified diet can be helpful. Here are some examples. The photograph on the left is normal meal. What's on the right is texture-modified meal. These meals have been looked into and developed individually at hospitals and long-term care facilities as they devised and modified the diets. However, some had no scientific basis, or various names and definitions of modified diets were used, causing confusion every time the patient moved from one facility to another. This will lead to patients' disadvantages. It was obvious that we need evidence-based criteria, including degree of difficulty in eating and swallowing, and the need for unified name was also obvious. So, at JSDR, we developed the guideline defining the dysphagia diet for rehabilitation for patients who develop dysphagia. This was established in 2013 and was revised in 2021. As shown on the illustration on the left, there are broadly 5 levels, and each of these are assigned a code. And the photographs shown would correspond with the code. As you can see, as the number in the code goes up, it becomes closer to a normal diet and would mean that the level of difficulties would be increased. On the other hand, the code with smaller number has lower difficulties, and the minimum number, code 0, is not a meal for the purpose of intaking nutrition. This is used for rehabilitation and test. This guideline ensures consistency with existing classifications used by food companies. So we have given due consideration so that this can be used by food industry. And we also created this so that large numbers of facilities can use the dysphagia diet. We have been popularizing this guideline for 8 years since the creation of the guideline. There have been some different usages. First, at medical institutions, long-term care facilities, they have used this for multidisciplinary cooperation within a facility for rehabilitation and nutrition management, and also for information sharing among facilities for patients' care. It was also promoted in the public medical and long-term care insurance systems, improving resulting in improvement in efficiency and appropriateness of medical and nursing care. It is also used for food delivery services and commercial food, leading to expansion of patients' dietary choices. One other major choice of the patient's diet is eating out at restaurants. We are trying to popularize this guideline by providing support for having training sessions and creating textbooks for the cooks who would serve the dysphagia diet in restaurants in town. We firmly believe that the creation and popularization of the guideline would lead to the benefits of the patients. And we also believe that this supports the life with dignity and to maintain quality of life for those that have dysphagia. That concludes the initiatives taken by our academic society. Thank you very much for your attention. Thank you very much, Professor KOJO. So the field of dysphagia is very much an interdisciplinary field. So in that context, you created the guideline. So those that are in different fields, they can be on the same track and they can move in the same direction. So this must be hugely useful. On the other hand, what's important is that the experts pay attention and be interested in this field. So you, Professor KOJO, is also a professor at a university, and you're in a position to instruct the university students. What is the reaction and level of interest among the students? Those that enter our university are not that knowledgeable about medical institution or the long-term care facilities, but on TV, news, and newspapers, they hear about the aspiration pneumonia or dysphagia. Those terms are covered in the media often these days. So they have the sense that they have to do something about this issue as they enter the university. That's the impression I have. So over the 4 years at the university, they may not reach a satisfactory level, but in classes at the university, it seems like they have a high level of interest in the dysphagia diet. I wish you all the best in training those that are interested in this area. Thank you very much. Thank you.
Now I'd like to have a final presentation. So we'd like to welcome Ms. Daisuke MUROTA from Skill Development Center for Cooking Technicians. The center provides a training to licensed cooks on how to make dysphagia diet. So this is the national license for license to cook that is provided by the center, and we hear 39,000 people have passed the license cook test, and also they are developing the leaders who can lead the initiatives to improve the diet at workplaces. So they are the experts of the cooking and letting them understand the importance of dysphagia and creating the meals adjusting to that. I think that's very important initiative. So Mr. MUROTA, please. So hello everyone. I'd like to talk about the dysphagia diet for elderly people. I'm MUROTA. Nice to meet you. So I am at the Skill Development Center for Cooking Technicians, and I am also is a member of the Dysphagia Diet training expert meeting, and I'm certified cook specialist, certified skilled cook. I think people tend to say, and you are what you eat, and I think it's true. So at our center, we carry out qualification tests for certified cook specialists, certified skilled cooks, and licensed cooks. So when they acquire qualification, so by having knowledge and skills, they carry out projects to contribute to the improvement of public health of the people. So the significance of the training is shown here. So at the center, so in this aging society, so we'd like to make it possible to provide a dysphagia diet in general cafeterias and restaurants so they can enjoy eating rich diet life with their family and friends, despite of having impaired swallowing functions. So in order to do that, we are providing trainings for licensed cook all over the countries. And this training is conducted as a national treasury subsidy project from the Ministry of Health, Labor and Welfare. So these are the contents of the training materials. In the materials, information such as swallowing function, the basic knowledge about dysphagia are included. And we, licensed cook, also come up with good recipes, and those are shown as an example, so other cooks can put them into practice. And as so this is the level three level of the care needs people. And as you see on the slide, I am a Japanese cook. So in my profession, I would like give regular customers who have weakened swallowing function due to the aging. So I want them to feel the joy of eating together with their families and friends, enjoy the same food deliciously. So out of which I am doing this. So I have the principles as a Japanese cook. That is to satisfy five senses of cooking. First, eye, the visual. You enjoy colors of dishes on the plates. The dishes are the dresses of the plate. The mouth, savory. You have different five senses: sweetness, sour, bitterness, or the umami, the savory, and with a pinch of salt. Each flavor is enhanced. And olfactory, the smell of the seasonal ingredients, and tactical enjoyment, the hardness, softness, and auditory. So you talk to regular customers, or maybe beforehand you ask the families the information what they like. And after having meals, we will get the feedbacks. And we want the licensed cook to receive this training on dysphagia, and would like to increase the number of cafeteria, the restaurant across the nations who serve swallowing adjusted foods. So this shows the Japanese traditional foods, and we use cooked rice. For example, in case of the rice puff, water will rice and made into puff using a puff machine. And you can eat as they are, but if you put some water, it can be gelée or paste, and they can be used for sauce. First, you will put the rice pulp in water for about 30 minutes and mixed that with alpha-made rice flour in a ratio of 1 to 3. And that will be heated when served in the microwave oven. And as for unagi, grilled eel, so first pieces of eels are grilled and leave to remove heat and remove the skin, mince the skins, and eel meat are cut into pieces and steamed. And basic rice made previously is heated in a microwave oven and mixed with sauce and minced skins. Put these in the dish bowl and put steamed eel's meat on the top and serve them with Japanese sansho green pepper. And after that, we will get in feedback. So how did they like the softness, the degree of the water, and so that's what we do. And also we take the soup stocks from vegetables. So those coming from plants. So we coined the phrase e-repsol. And the soup stock was created from vegetables and dashi soup stock. And so 5 different vegetables are boiled, and before boil in 4-liter water and kelp in it. Before boiling, reduce the heat and simmer for 14 minutes and heat up. And right before boiling, put a pinch of salt, reduce heat, and skim off the scum. I do not throw away vegetable cuts usually, and edges and skins are kept. Use them for soup stocks. That is for SDGs. And so this is a really good harmony of the soup and e-repsol can be drunk as they are, eaten as they are, or can be used as the base soup. As for the peas, take beans out from pea pod and boil to soft enough and put them into water and drain and add something to make it thicken like starches and put the family minced citron on the top of that, and this is the creating a good harmony of soups with the peas. So this is the stir-fried sashimi fish with egg white, blue salt. So first, dumpling made of fine grounded fish paste and egg white with green seafood sauce. The so with the zanchuan into the fish paste, knead well, and also with the white egg and blend them together and put the starch and deep fried a spoon of portion and boil them and you season them and with a little starches and to thicken and serve in the plate. So we'd like to provide the enriched diet to the elderly to enjoy. So at Development Center for Cooking Technicians, we will work together with licensed cooks to create a society where all citizens, especially the elderly, can enjoy a rich diet. Thank you very much for your attention. Ms. Murota, thank you very much for presentation. So you are the Japanese cook, you said, so you are the expert of a licensed cook. So when speaking of Japanese cuisine, we imagine a traditional Japanese food. But when we say tradition, it's not something we protect something old. The tradition needs to be also cherished but evolved. So while protecting the real value of Japanese, you try some different way of cooking by preserving the value. that was amazing. So actually, we are about to lunchtime in Japan time, and I saw a lot of delicious pictures, and I felt strongly the power of foods. But on the other hand, although the meals for the elderly, those cannot be less tasty for the sake of dysphagia. So the delicious foods should be provided as equally as those for healthy people. We only saw the handful example of meals for dysphagia patients, but I think they are also delicious to healthy people. Yes, thank you very much for that comment. We are working hard to create many more delicious recipes. Thank you. So now, so under the theme of the improvement of nutrition, we listened to the various presentation of various discipline, academias, local governments, private sectors, and technical or vocational organizations. So in the process of project working with licensed cook, of course, meals or the eating themselves are important, but that is one of the medias. What can be communicated? What message can be communicated through that eating or the cooking? So I try to communicate the importance to my students. The eating is very important, but to chef or the cook, those who serve are equally important, and the human-to-human relationship of these people really matter. So on the other hand, there are people who have difficulties to take food or enjoy food. How to support them is an important thing. But for example, so from the medical point of view, so the value of albumin in blood circulation could mean the sufficient nutrition. However, that's necessarily be the case because, to me, under the nursing care insurance, I am thinking how to prevent people from becoming the support needs stages. And one thing I heard is that prevention of nursing care is not just improving the condition of the patients. So even patients, the condition cannot be improved. Still supporting patients to trying to be independent, to realize what they want. So that's what I heard. And this is said by the former chairman of the Japan Physical Association. Through the meals. So we want the elderly people, many more people to enjoy the eating. And we like to send such messages from Japan. So this is one of the very objective of this Japan Growth Nutrition Summit. I apologize for extending the meeting, but thank you very much for presenters and also the audience all over the world. Thank you.